Hello, everyone, and welcome to the National Council live webinar in partnership with the Novotel Telepsychiatry, titled Telepsychiatry, A Year in Review and Beyond, and What's to Come in 2020. My name is Amber Williams, and I'm the Communications Manager for the National Council for Behavioral Health, and I will serve as your moderator today. Today's webinar is being recorded, and you are currently in listen-only mode. We will hold the question and answer time at the end of the webinar, and we'll answer as many of your questions as time allows, but please hold off on sending your questions until the end of the webinar. Within 48 hours, an audio version of the entire webinar and a PDF of the presentation will be available on our website at thenationalcouncil.org. I would now like to introduce to you John Evans, CEO of Novotel Telepsychiatry, and Lauren Lashbrook, Director of Strategic Partnerships. And now, Lauren, over to you.
Thanks, Amber. My name is Lauren Lashbrook, and I'm the Director of Strategic Partnerships with the Novotel Telepsychiatry. We want to thank the National Council for allowing us to partner with them in bringing you this webinar today. We're going to spend the next 30 minutes covering a few topics that we've outlined, really taking a look back over 2019 and what's happened in telepsychiatry, and then what's to come in 2020. So we'll start by giving a brief overview of Novotel Telepsychiatry, who we are and why we do what we do. Go through a few telepsychiatry buzzwords, some regulatory updates. We also had the opportunity to poll a few industry experts throughout the behavioral health and telemedicine industry to share their highlights of 2019. And then we also had the opportunity to interview two of our clinic partners, two CEOs of busy community mental health centers that have deployed telepsychiatry to share some of their success stories with you. And we'll also have time at the end for questions and answers. As Amber said, we'd like to hold off questions being submitted to the end. We had quite a few questions submitted ahead of time, and we tried our best to incorporate those questions throughout the presentation today. So just to get started, a little bit of background on who we are. We are a clinician-owned and operated telepsychiatry company. We like to say, we are you. And Novotel was founded by a clinical team with over 30 years of behavioral health experience. And the founders of Novotel actually started the first freestanding community mental health center in Northwest Pennsylvania and got started using telepsychiatry through a small SAMHSA grant about 10 years ago and developed a really successful telepsychiatry program there 10 years ago, where technology was nowhere near as advanced as it is today. And they deployed telepsychiatry 10 years ago because psychiatric recruitment and retention was a constant challenge. And we know the psychiatric provider shortage has grown even more so today. And so through word of mouth, the clinic's adoption and success using telepsychiatry spread quickly throughout the state of Pennsylvania and the rest of the country. And now Novotel Telepsychiatry has been serving in telepsychiatry partnerships with clinics across the country for the last 5 years. We currently have psychiatrists, psychiatric nurse practitioners, and licensed clinical social workers on our team. And we partner with organizations that are looking to grow their treatment teams either part-time or full-time with our providers. We manage all recruitment, licensing, DEA, benefits, and malpractice for our clinicians. And one of the things we're really proud of is that we don't just assign clinicians to work in clinical settings. We allow our clinic partners to tell us exactly what they're looking for in a clinician, and then you get to interview our team and choose the provider that will be joining your team. And we're very proud that we currently have a 95% retention rate. So of all the clinics we partner with, 95% of them have had the same clinician the entire time we've worked together. And we also feel that continuity of care is really critical in behavioral health. So with our model of telepsychiatry, you have a dedicated provider that holds a caseload and your patients see the same provider at each and every visit. That also allows for your clinic team to build relationships with your provider that's joining virtually through telepsychiatry technology. So we're going to jump over into some of the regulatory updates from throughout the year. But before we do that, I just want to share a few terms and buzzwords to know. I'm sure most of you on the call today know, but telepsychiatry, just at a high level, is the delivery of psychiatric services utilizing a HIPAA-compliant connection. Through telepsychiatry, we're able to use the reduced number of active psychiatrists and allow them to treat more patients all over the country. We have found, and many studies have found, that it's equivalent to in-person care in diagnostic accuracy, treatment effectiveness, quality of care, and patient satisfaction. As we go through, I'm going to pass over to John Evans, our CEO, to go through some regulatory updates, but just 4 terms to keep in mind. Coverage parity is a parity law that mandates the coverage of telehealth services. Payment parity is a parity law that mandates equivalent reimbursement of telehealth to in-person services. And then 2 terms that come up very frequently are originating site and distant site. Originating site is the site where the patient is located, and the distant site is the site where the provider is located. So John, I'm going to go ahead and turn it over to you to talk through some of the regulatory updates.
Well, thank you, Lauren. I appreciate that, and appreciate the opportunity to work with the National Council on this webinar. And as we talk about this, keeping in mind that I'm sure, as everybody knows listening in, that oftentimes technology and advancement in care usually outpaces the regulatory environment. So we're always pretty much continually working together with both the federal and state governments and other regulators to talk about the need to move things ahead so we can continue to provide care. But as we've expanded our footprint, we found in the current environment that the states do have some oversight in the regulatory requirements for the delivery of medicine specific to telemedicine, and that currently literally no 2 states are alike, so we have to do a fairly deep dive into each state as we enter into that platform or that footprint. Fortunately, we have a compliance officer who is an attorney and a physician, and she does a fairly thorough review of those regulations before we get started. However, with that said, states are continuing to define and expand telehealth policies in regards to reimbursement and how care is being delivered, not only by a physician, but also by psychiatric nurse practitioners and licensed clinical social workers. So we really are encouraged that states are starting to look at this. At this point, we can say, though, that 50 states and Washington, D.C. now provide reimbursement for some form of live video Medicaid fee-for-service program. Next slide, Lauren. So some terms to know in regards to this are just the delivery of psychiatry via telepsychiatry. We specifically, thanks, Lauren, we did go the wrong way, didn't we? So some regulatory updates. Allowing the home as an eligible originating site was a common pattern throughout Medicaid policy reform over the last few months. There's been a lot of discussion about that. There is some federal legislation that is starting to go through Congress that will help support that, some that's been passed. Most Medicaid plans no longer follow the Medicare rural requirements. However, there's still some limitations in regards to where we can actually geographically provide telepsychiatry. Some states have recently added a home as originating site. Some examples are California, Kentucky, Ohio, New Hampshire, and Colorado. We're hopeful that other states will follow suit. And 40 states have private payer telehealth reimbursement law. Thanks to the Parity Act that I think Patrick Kennedy helped pass over 10 years ago, we're now starting to finally see some progress with parity. We have a long way to go, and I would say in relation to that, I was at actually a panel discussion in DC today at a payers conference, and I think Dr. Arthur Evans made some great comments. Dr. Evans is the president and CEO of the American Psychological Association. And I think he outlined well that the fee-for-service configuration for payments is really outmoded. It does not support the goals that we're all looking for in regards to provision of care. So he outlined some interesting ideas that we all need to talk about in regards to payment for care. With that, what we would like to be with our partners, and frankly with anyone that's interested in this field, is advocates for the pre-wins. So let's go to the next slide, Lauren. Lauren, can we go to the next? There we go. Thank you. Probably the most significant federal act, and I'm sure you're all aware, is the Rhine High Tax, which was established in 2008, that really limits the prescribing of controlled substances via telemedicine, unless there's a practice of telemedicine is met. And some of the regulations in the Rhine High Act are I think we understand were important at the time. That the act was actually passed because a young man named Rhine High unfortunately purchased medications over the internet, and he died as a result of that. And so this act was put into place. The requirements are somewhat difficult in regard to the provision of the prescribing of Schedule II medications. The telemedicine community, along with other national organizations such as the National Council and the American Telemedicine Association, we've all been working to advocate with the DEA to establish the regulations that allow the prescribing of these medications according to the standard of care. So there should be no difference in the provision of telepsychiatry in the traditional model when it comes to prescribing Schedule II medications or doing medically assisted treatment. As a part of that, really, fortunately, the Support Act was passed in Congress. It was supported by the administration. The DEA was given a deadline to outline these new regulations. Unfortunately, that deadline has passed, and we have not heard from our colleagues at the DEA. Needless to say, that was very disappointing. We were all eager to hear about the draft regulations and make comment. I can share with you that I know the National Council, the American Telemedicine Association, and the American Psychiatric Association all wrote very thoughtful letters in regards to comment on this. So we're hopeful that that we'll still have an opportunity to do this, but as of yet, the Rhine High Tax is still in place and we do not have any of the waivers.
Thank you, John. And Amber, I just want to make sure, can you hear me speaking clearly? John, you did go in and out a few times and there were some comments that came through. Are you able to hear me clearly, Amber?
Yes, Lauren, I can hear you.
Okay.
Great.
Thank you, John. And I was following the slides with you, and I know we did have some questions coming through on MAT specifically, so we'll make sure we cover those at the end, just in case there was anything that was missed there, and we are going to cover Rhine High and some of these upcoming questions as well. When we asked the experts in the industry, really looking back over 2019, this topic did come up with two of our experts, so we'll go through, and if anyone has any audio issues, please let us know, but hopefully we won't have any more technical issues. Thank you. So the first person we spoke with is Nate Laxman. Nate Laxman is an attorney and partner with Foley & Lardner. And if you haven't had the opportunity to see Nate speak, really try and see if that's something you can work in your schedule or attend a webinar of his next year. He is such an advocate for telehealth and progress. He has a tremendous blog that it's a phenomenal resource if you're looking for all things regulatory updates. When it comes to telehealth, he's been a mentor of mine and just tremendous for our industry. And so when I asked him these questions, he shared the following and want to share this with you today. Looking back over 2019, the biggest progress in telehealth has been the growth of direct-to-consumer offerings. More companies are learning how to effectively and safely deliver telemedicine services directly to consumers. Over the next 3 years, this will fundamentally change the landscape of how healthcare is delivered and where people turn to for expertise. And so we echo Nate's excitement on this and are seeing a lot of changes moving in that direction to really open up access to care. And the day Nate and I spoke was the day that was the deadline for the DEA to make the updates. And so Nate also provided this quote, although the DEA appeared to blow off Congress's Rhine High Tax deadline, its policymakers did find the time to prioritize drafting and publishing a different regulation defining certain fentanyl derivatives as Schedule I controlled substances. So the DEA is certainly publishing regulations, just not the regulation Congress and the President enacted a law to publish. While it is useful for DEA's illegal diversion control efforts to reclassify fentanyl derivatives as a Schedule I controlled substance, I believe it would be more beneficial for patients for the DEA to publish regulations activating the special registration process. After all, this deadline was a part of the Support Act. And so we're hopeful that we will see some progress along these lines, maybe possibly towards the end of the year or hopefully in 2020. We also spoke with Michael Gomez, the CEO of the Clear Health Quality Institute. For those of you that may not be familiar with CHQI, they are the accreditation agency for telemedicine that has been endorsed by the American Telemedicine Association. And as you can see, Michael gave me a tremendous amount of information to share that we're really grateful for. I won't read all of this to you because the slides will be provided after the presentation, but a few things really stood out that Michael shared in his role. At CHQI, they've seen an increased focus on standardization in the telehealth space. Many organizations are building successful telemedicine programs and taking a hard and close look at how they can refine and streamline policies and procedures that are really focused on improved quality outcomes and operational efficiencies. And really one of the big focuses of CHQI is to really demonstrate how the value of telemedicine can have comparable or better outcomes to in-person care. And that's something as an industry, I think we're all working towards in the telemedicine space. We all have anecdotal stories we can share, but really using that data to show how impactful telemedicine can be in all specialties is something we're all looking forward to in 2020. Clear Health Quality Institute specifically is launching 2 new programs in 2020 that some of you on the call may be interested in. They're launching an outcomes supplement to the telemedicine accreditation program late this year, and they're actually welcoming their first applicants. It will provide the first opportunity for telemedicine programs to have an accreditation agency validate the strength of their outcomes measurement programs, and will also demonstrate the emphasis on implementation, analysis, and reporting of specific telemedicine program outcomes. Next year, they're going to be launching their first remote patient monitoring accreditation program in early 2020, and they're actually going to be opening this up for public comment this month. And this is really important because these will be the first accreditation standards in this area that they feel are a very important critical step in protecting patients. We also spoke with Tanya Malik, who is the chair of the American Telemedicine Association Telemental Health Committee. John Evans, our CEO, sits on the special interest group alongside many other telemedicine industry leaders. And she shared that looking back over the year, one of the biggest standouts was the passage of the Support Act, which she considers a major victory for the industry. The Support Act, for those that may not be familiar, accomplished 2 really major things, and one being the allowance of reimbursement for Medicare beneficiaries to be treated at home for substance use disorder and co-occurring mental health disorders. This is really important because we know that 5.7 million adults ages 50 and older will have a substance use disorder, and Medicare beneficiaries are more likely to suffer an overdose than those on private insurance. So the Support Act really allowing an increase in access to care there has been huge, and we're excited to see more progress there. Tanya also shared our frustrations with the deadline coming and going with the Rhine High Tax. We know by now that they missed that deadline, but her special interest group does have a plan to move it along, but right now we are in a bit of a holding pattern to see what happens there. Looking ahead to 2020, Tanya was really excited that Medicare Advantage plans starting in 2020 are going to be allowing to be receiving telehealth services in the home. We're also, of course, hopeful the special registration requirements for the Rhine High Tax are completed. Something that the special interest group for the Telemental Health Committee is focusing on, which is really a huge issue in the telemedicine world, is licensure. And they're really working so that US licensed physicians who are living abroad can treat patients that are living in the United States. And they really feel like this would help with the physician shortage. So we're hopeful for that as well. And then she wanted to keep an extra special eye on non-traditional healthcare companies that are starting to make a big move in telehealth. She specifically recommended keeping an eye out for Best Buy, Amazon, and some of the pharmacies as well. And we'll close out the panel session with Chuck and Ghoulia, President and CEO of the National Council for Behavioral Health, and been very supportive of telehealth as a way to increase access to care. And he shared that more and more people are discovering that telehealth is a convenient way to support access to high quality care. Congress and the administration have had an opportunity to make telehealth more accessible. So again, we think it was a really great year. There were some disappointments specifically with the Rhine High Tax, but much to look forward to in 2020 and major progress from the past year. So now we're going to transition into hearing from some of our clinic partners. Many of you sent questions ahead of time wanting to hear how people have used this, what kind of impact it's made on their patients, how does it work in a clinic setting. Instead of us telling you, we thought we should talk to some of our clinic partners and you hear it directly from them. So over the last 5 years of providing telepsychiatry, these are really the 5 top things we hear day in and day out of why people are turning to telepsychiatry as a solution. And I'm sure many of you can relate to this. Long patient wait times, the psychiatric provider shortage, recruitment challenges, clinician turnover, and limited access to care. So the first person that we spoke with was Shauna Reitmeyer. Shauna Reitmeyer is the CEO of Northwestern Mental Health Center, which is also a member of the National Council for Behavioral Health. Northwestern Mental Health Center is also a CCBHC, and they serve individuals and families of all ages. And their mission is to promote wellness and instill hope across their region of rural and frontier Northwest Minnesota. Shauna and her agency were one of the first agencies in Minnesota to utilize telepsychiatry when it became allowable through Minnesota Medicaid and other health plans. Novotel has been working with Shauna's group for 5 years and currently has a part-time child psychiatrist with us. And we are also in the process of adding a medical director to their team through telepsychiatry, which is really exciting. So when I asked Shauna to share with me what drove her to explore telepsychiatry 5 years ago, she shared the following. Our agency covers 6 rural and frontier counties in Northwest Minnesota, where recruiting for most challenging disciplines such as psychiatry was compounded by our location. We took the initiative to work with an existing provider who moved away back in 2008, and then we grew to incorporate a child psychiatrist with a Novotel on our prescribing team. And when asked what telepsychiatry has done for the clinic and your patients, she shared some stories that really focused on convenience for the patients and access in the community. By doing telepsychiatry, it's allowed their patients to access the service in locations where they live without having to drive to our primary clinics that can be upwards of 1 hour away. A great example was recently we were able to have one of our RN care coordinators do a home visit and connect through telepsychiatry with one of our psychiatrists to address medical issues and medication changes where it was challenging for the client to come to the office. Because of this technology, more clients are able to get the service they need at a time that works for them and prevent increased symptoms. It has increased coordinated care and overall meeting our mission. So we're grateful for our partnership with their clinic and always grateful to partner with innovative leaders that are looking at telepsychiatry as a way to increase access to care. And another one of those innovative leaders and innovative groups is Woodland Centers, also located in Minnesota. So we had the chance to speak with their CEO, Dr. Ashley Kios. Woodland Centers is a private nonprofit community mental health center. Their catchment area encompasses 5,100 square miles, and they serve approximately 5,200 individuals each year. They've also been partnered with a Novotel telepsychiatry for the last 5 years. They currently have 3 psychiatrists with our partnership, seeing both children and adults. And they recently added a full-time licensed clinical social worker to their team through us. And we're also adding a medical director there as well through a telepsychiatry partnership. So I asked Dr. Kios the same questions. Woodland Centers was struggling to obtain and maintain psychiatric providers in our rural area. We had long wait lists for services and continued to receive feedback from our communities and partners about our inability to serve clients in need of psychiatric services in a timely manner. Telepsychiatry through a Novotel provided us the needed resources in a timely manner so that we could better serve our clients and our communities. She also shared that telepsychiatry enabled them to provide reliable and consistent psychiatric services. She felt that our providers are professional, knowledgeable, efficient, empathetic in their work. And we feel the same, that our partnership with them has been invaluable. And Dr. Kios also shared a story, and again, this is a lot of text on the slide, and I won't read this whole entire story, but I wanted to share a lot of questions that were submitted ahead of the webinar were about how patients respond, or are there certain patients that are not appropriate for telepsychiatry? And Dr. Kios shared the story, and I'd like to share the highlights with you. A 13-year-old boy presented to Dr. Eberly, who is one of our psychiatrists that works with them, in March with complaints of sadness and verbal outbursts. He was struggling in school, both academically and socially, and was easily frustrated, extremely emotional and disruptive to peers, and he was quick to anger. He also presented with OCD-type symptoms. The client was started on Celexa and later switched to Effexor. And after 1 month of this medication change, the client's mom called and was crying, reporting the client was doing extremely well, the best we had ever seen him. Her son is engaging more at home. He's happier, smiles more, and is no longer irritable or crying. His OCD symptoms improved significantly. He's no longer feeling the need for his symptoms that he had before and has shown drastic improvement, especially his symptoms that he had had since the onset at the age of 2, and he continues to show progress. This telepsychiatry medication management treatment is allowing him to be fully engaged socially, interpersonally, and academically. And I love this story for a lot of reasons. First of all, that the patient is getting access to care and the treatment that they needed. But what I love even more about this story is this is not necessarily a telepsychiatry story. This is a psychiatry story. And we really feel that telepsychiatry is psychiatry. There's not a mention of the video in this story or what felt different with telepsychiatry. This is a case of a patient getting the right level of care with the right psychiatrist that was able to treat the patient in the way that they needed. And I think this is just one of many stories we've had the opportunity to collect over the last 5 years that's really focused on patient outcomes and doing what's right for the patients. And so I'm now going to pass back to John quickly to do an overview of what we're looking forward to in 2020 from his perspective.
Thank you again, Lauren. Can you hear me better now?
Yes, I'll let you know if it cuts out.
Okay, thanks. Working with a little technology in Washington, D.C. And again, I appreciate the overview. Especially, I appreciate the feedback from our partners in care. These are really amazing agencies with capable leaders who accomplish quite a bit with very few resources. One of our main issues, and I think I mentioned this earlier, that we want to really focus on is to continue to work with payers in regards to a sustainable rate for outpatient behavioral health care. We know from data and from our experience that when timely access is achieved, the triple aim is at hand. So we improve access, we improve outcomes, we lower costs, and patients are across the board more satisfied. So we're going to talk a lot about that both now and going forward, that we think that, this is a fundamental solution to the challenges that we're all dealing with in behavioral health and addictions care. We also want to further the work with the Telehealth Committee of the American Telemedicine Association to continue to find an acceptable path forward so we can start providing MAT waivers to current clinics under the Rhine High Tax. We do have clinicians that have certification to do buprenorphine treatment. However, we can't use them at the current time under the current restrictions. We also want to continue to advocate for a more efficient and timely path to interstate licensure for all clinicians to provide behavioral health care. As you're all aware, each state has its own licensing board and process. That can take anywhere from a month to up to a year, depending on the state, for a perfectly credentialed and trained clinician to obtain a license. Our feeling is in the world of telemedicine that we really like to advocate for a national standard to move forward where states can register clinicians and have a fee structure, but that the license would be more of a national perspective. In Novotel, we were honored to be accredited by the Clear Health Quality Institute. That was achievement by our clinical team and our compliance officer, and we're looking forward to continue to provide care at the highest level under the provisions of the accreditation. Additionally, we're looking forward to continued strategic partnership with the National Council for Behavioral Health. We want to continue in partnership with the National Council to advocate strongly for timely access to care. I've really heard Chuck and Ghoulia's advocacy loud and clear, especially with the more rural providers and the small providers who really tend to struggle with not only recruitment but retention of good clinical staff. We would like to be a partner to achieve that goal. And then we're looking forward to our continued work with our newly established Strategic Advisory Board. We're really honored to have Patrick Kennedy and Linda Rosenberg agree to be the co-chairs of that committee, and we're looking forward to the guidance they're going to provide in the coming year. Thank you, Lauren.
Thanks, John. So we're going to move into the question and answer session. And I do see some questions coming through. And I did take a look at some of the questions that were submitted ahead of the webinar. So I've got a few questions written down we're going to address. We have about 15 minutes left. Some are going to be covered on these 2 slides. So this is going to be our FAQ speed round. So I'll walk through these quickly. And again, the slides will be submitted. But one of the most commonly asked questions, how does licensing and credentialing work? John just touched on this. Licensure definitely has room for improvement when it comes to efficiency and timelines. However, the rules are clear that the provider needs to be licensed in the state where they are physically located and the state where they are providing services. So for example, I am based in Florida, and if I am a psychiatrist providing services to a clinic in Minnesota, I will have a license in both Florida and Minnesota. And a Novotel does cover the cost of licensing providers in multiple states. With billing and reimbursement, there were a couple of questions that came through with questions specific to your state. And someone specifically had asked regarding, are there certain resources that have state guidelines? And yes, there are. So there are a few that are outlined here, but highly recommend checking out the Center for Connected Health Policy. On their website, they actually have an interactive map where you can click your state and it shows all of the regulations, reimbursement guidelines, and everything is done in real time. So if there's anything pending in your state, that is the place to go. The American Telemedicine Association also has state-by-state guidelines as well. And then each region of the country has a telehealth resource center. And those are there for you as a tremendous resource. So I would recommend reaching out to all of those. And then most importantly, contact your payers. Even if there's a parity law in your state, it is very important to understand the insurance policy for the plans that you're going to be billing services for. With our model, our providers become credentialed with your payers and you do the billing for the telehealth services. Patient satisfaction, how do patients respond? We've had tremendous patient satisfaction results. We've actually had clinic partners share that our telepsychiatrists in some cases have higher patient satisfaction results than their on-site providers. I think that comes down to the quality of providers we're hiring. We're extremely selective. But what I would share with anyone that's considering implementing telepsychiatry or telehealth in any capacity is to manage expectations and to do patient education. No one likes surprises. So what we found is that the best telepsychiatry programs really have a detailed implementation that include how to educate staff on how to explain this to your patients. When we partner with an organization, we do a lot of hand-holding to make sure this is implemented the right way, that everyone on the team knows how to explain this to patients. Some of our clinic partners will even walk patients into their telepsychiatry room to show them what it looks like, introduce them to the psychiatrist. So it really comes down to education, and we've seen little to no pushback with telepsychiatry. It's probably not for every patient, but there's not really blanket rules across the board on who is this not for. There was a question that came through if there's restrictions with adolescents. Again, there are no across the board standards for adolescents not being treated via telepsychiatry. We have a high volume of child and adolescent psychiatrists on our team that treat children through telepsychiatry. What will be really important to look into and have your compliance team look into are the consent requirements in the state and what your payers require. The effectiveness of telepsychiatry versus in-person care, the standards of care remain the same. We feel very clear that telepsychiatry is psychiatry. We don't treat it any differently. And we've heard stories over the years of patients that are actually preferring telepsychiatry to traditional in-person care. One of our clinic partners that has a therapist with us has had patients share with them that with patients that are struggling with anger management, they feel more calm in a teletherapy appointment and they feel more comfortable when there is a barrier and the clinician's on screen. Many of our child psychiatrists have expressed that children on the spectrum are more engaged when a screen is introduced and do really well with telepsychiatry. So those are some things that we've heard over the years. Safety is critical. Patient safety and quality are our top priorities. As John shared, we're accredited through Clear Health Quality Institute, but it's really important to make sure that for us, that with our psychiatric services, patients are still presenting in clinical settings or a setting where vitals can be captured to meet the standards of care. So as one of our clinic partners shared, that may be outside of a clinic setting, but we're partnering with a care coordinator or on the ground nursing staff or an ACT team that's there because we're really focused on patient safety and meeting those standards. Technology is really no longer a barrier. It has come a long way in the last 5 years, and the technical requirements are pretty minimal. We've got detailed recommendations for our partners that have produced the best patient satisfaction surveys, but really strong internet connection and a high quality webcam can get you started on a telepsych program. Really important that you use a HIPAA compliant platform. There are a number of systems on the market that even have the ability to publish a strong video connection, even in rural areas where there are bandwidth challenges. And if you partner with us, we provide you with that software at no cost. And one final question that a lot of people asked us about before the webinar was, how do the telepsychiatrists engage with on-site clinical staff? With us, we feel that collaboration is possible with telepsychiatry. Our goal is that our telepsychiatrists are just as much a part of the team as if they were there on site. The only difference is that they're connecting via video. So our providers participate in treatment team meetings, and we have an open door policy. Our clinicians stay on screen the entire time that they're scheduled with a clinic. So if you have a provider Tuesday and Thursday, 9 to 5, even if there's a change in the schedule, they are on screen during those times. So we really encourage that collaboration. So if there was a shift and a provider has a free 20 minutes, that a case manager or a therapist or another clinician can pop into their office, just like if they would, if they were physically there within the building. So John, I'm gonna turn it over to go to some live questions and see what we have here. Again, with some of the state specific questions, it would be really hard for me to get through all of these today. So again, I would really encourage you to reach out to the Center for Connected Health Policy, the American Telemedicine Association, or your telehealth resource center, or you are free to email John or I these individual questions regarding specific states, and we'd be happy to answer those. Unfortunately, it's not black and white and very easy to answer on a call. I have a question from Cynthia. Are the associates that work for a Novotel employees independent contractors or employees of ours? All of our clinicians are employees with us. And again, we have very high standards for the clinicians that we're bringing on board to join our team, that they are all clinicians that are employees of a Novotel. John, I'll pass one over to you. We've got a question. What are some key performance indicators commonly used for telepsychiatry, not used in traditional psychiatry? Maybe if you want to speak to kind of what we do from a quality control and how we handle that.
Sure, yeah, we look forward to working very closely with the clinics, as Lauren said. We have a very defined process in regards to onboarding, very detailed list of specifications for how to set up a telepsychiatry room that is really very minimally expensive, but we found there are a number of issues that if you set it up right, patients give us consistently positive feedback in regards to their satisfaction with the service. And then on an ongoing basis, probably equally important, if not more so, we have a team of psychiatric nurses that works hand in glove with the staff on the ground as our partners to ensure that we continually have the highest level of service available. So we're true partners, not at the beginning, but on an ongoing basis.
Thanks, John. A couple of questions that are along the same lines, so I'll try to answer these as a group. Mark had a question, how are medication issues or questions addressed when the psychiatrist is not scheduled? That's a great question. With all of our clinic partnerships, we have a clinical liaison that works with all of our clinics, and they're actually all trained psychiatric nurses that your entire team will have access to. So if you have a psychiatrist with us there on Tuesday and Thursday, we know that questions may come up Monday, Wednesday, and Friday, or throughout the rest of the week. So that clinical liaison that is a psychiatric nurse on our team will be a liaison to your entire team. And then we try to handle non-emergent issues on the day that the providers are there, but the providers are definitely available. And then you have the additional support through our clinical liaisons. Liz had a question, if the organization is doing the billing, how do the providers get paid? Great question. We charge an hourly rate for the clinician services, and that's set up front based on the amount of hours that you have them per week. Someone else asked if an organization contracts with you, Mr. Nelson, for psychiatric nurse practitioner services, can we provide supervision? The answer is yes, in most cases. There are a few states that have some geographic requirements on proximity for the supervising physician, but we're seeing those become less and less prevalent. So we do provide supervision for many of the nurse practitioners, or sometimes our clinic partners are providing supervision for our NPs. We work closely with the team to determine what's best. Have a lot of questions about why do we just have LCSWs versus LMHCs. Right now, that is because of Medicare restrictions, unfortunately, with the ability for LCSWs to exclusively bill for Medicare services, but we would love to hire LMHCs as well, but many of our groups are high Medicare patient populations that have LCSWs as a requirement. John, is there anything else you'd like to add to the LMHC? Or
yeah, I would. Lauren, we certainly value what they bring to the treatment team. We do see that starting to change on a state-by-state basis, and hopeful that more payers, including Medicare, will see the value. So as soon as that path is cleared, we would really look forward to bringing that level of clinical staff on board.
Great. Couple more questions. We've got a few minutes. I've got a few questions about how do we handle language barriers, and can you work with patients who are not fluent in English? Absolutely, we can. We are very lucky to have a number of bilingual providers. We've recently placed quite a few bilingual English and Spanish speaking child and adolescent psychiatrists, and also we just hired a bilingual psychiatrist that sees children and adults, which is really hard to find. So we work really closely with our clinic partners that if that is a need that you have, we also had clinic partners that have worked with translators, but we know that the preference would be to have a provider that speaks the language. So that is something we've been able to navigate with our clinic partners before. And again, because we're recruiting nationally, we can find clinicians from all over the country versus looking at an immediate geography. So if you are looking for bilingual providers, please shoot me an email. We do have some additional bilingual providers that have recently joined our team. Hamilton asked, what has your experience been delivering telepsych in busy primary care settings? That's a space we're getting very busy with. Our chief medical officer was actually a part of the CMS Compass study that led to the development of the collaborative care codes. So we have a few models for how we partner with primary care settings. One is the traditional collaborative care model with providing curbside consults or attending treatment team meetings and reviewing complex cases with a primary care team, or in some cases also providing direct psychiatric services into that primary care clinic in blocks of times, where instead of a primary care provider referring out to a psychiatrist, they refer to the telepsychiatrist that is within the primary care practice through a Novotel.
If I could add to that, what's exciting is there's a number of payers that are seeing the value of that and starting to adopt over time those codes. So they're starting to map over in some states to Medicaid. And I'm serious using those codes as well.
John, you did cut out a little bit. I'm gonna guess what you said. I think I heard what you said, but that the collaborative care codes have been published for Medicare, but we are seeing more and more states adapt those codes into the Medicaid plans and even some commercial plans as well. So I think the more we see that, the more utilization we'll see, because of course being able to bill for these services is a really critical component. So Amber, we've got about 30 seconds left. I want to respect everyone's time on the call, and I'm so grateful for all these great questions that are coming in. Amber did send me the list of questions that came in ahead of time before the webinar. So if we didn't get to your question, please know I will follow up with you directly. And John and I's emails are on the screen. But if you have any questions about anything telepsychiatry related or what this looks like, there's a tremendous psychiatric shortage, and we know and we've seen telepsychiatry be a really effective way to bridge this gap in care. So we'd love to connect with you, and we want to thank the National Council for allowing us to host this webinar today.
Absolutely, and thank you, John and Lauren, and thank you everyone for attending today's webinar. If you have any other questions, you can contact us at communications@thenationalcouncil.org, and you will also be able to access today's webinar recording within 48 hours. And on behalf of the National Council and our presenters, thank you for joining us today, and have a great rest of your day.